welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Hi everyone, thank you for joining the 2nd November ACCP EMED PRN Journal Club. Today we have Taylor Fee, who is a PGY2 in emergency medicine at Jackson Memorial Hospital. She will be presenting a journal club on the comparison of initial adenosine dose conversion rate for supraventricular tachycardia in the emergency department.
Thank you for the introduction. Again, my name is Taylor and I am a pharmacy resident at Jackson Memorial. And we're going to be talking about adenosine dosing for SVT in the ED. So at this time, I have nothing to disclose. And I do have a quick abbreviations table for you. Hopefully most of you guys will know what they are, but I'll also be saying them throughout the presentation. Background for SVT. So SVT is a broad term which encompasses tachydysrhythmias. Relatively common. Prevalence of SVT is 2.3 per 1,000 people worldwide. Is divided up into different categories as stable or unstable. So for patients who present with unstable SVT, this is going to be your patients who are hemodynamically compromised in some sort of way, whereas in stable SVT, these patients are going to be hemodynamically stable and stable. And this is what the patient population that we're going to be focusing on for this journal club. As you know, SVT is seen relatively commonly in the ED. It's generally first treated with vagal maneuvers followed by our medical treatment options such as adenosine. That's a common treatment option for these patients if they are hemodynamically stable. Adenosine works by blocking conduction through the AV node where adenosine receptors are highly concentrated. When given adenosine IV, it is rapidly metabolized, making the half-life approximately 5 to 10 seconds. Although guidelines recommend initial and subsequent dosing of adenosine, generally that looks like 6 milligrams followed by 12 milligrams. That is dependent on patient, though. Effective doses can vary greatly for the patients that present to our ED. When it comes to the prior clinical evidence for SVT management, really one of the big trials looking at adenosine was conducted in 1990. This was a trial that looked at 2 prospective, double-blinded, randomized, placebo-controlled protocols of 359 patients. In that first protocol, they were looking at patients who received IV bolus doses of 3 milligrams, 6 milligrams, 9 milligrams, and 12 milligrams of adenosine versus placebo. In the second protocol, they were given 6 milligrams of adenosine followed by 12 milligrams of adenosine, or 5 milligrams of verapamil versus 7.5 milligrams of verapamil if they did not convert. As for the results of this trial, they saw SVT termination in 35%, 62%, 80%, and 91% of patients with the 3, 6, 9, and 12 milligram doses, respectively. When they looked at the second protocol of adenosine dosing of 6 milligrams versus the 12 milligrams, they saw termination rates of 6 milligrams at 57%, 12 milligrams showing a little over 93%. They looked at verapamil. 5 milligrams terminated patients VT in 81.3% versus the 7.5 milligrams, they saw termination rates of 91.4%. And really what this trial emphasized was that the overall efficacy of adenosine appeared similar to verapamil, which was commonly used prior to adenosine use, and also guideline recommendations such as the 2015 guidelines, which we'll talk about in a little bit. Following this trial in 1994, there was a prospective case series with the objective of determining feasibility and efficacy of adenosine in SVT management in a pre-hospital setting. So this looked at a little bit over 100 patients, and what they did is they gave 12 milligrams of adenosine IV, and if this did not convert the patients, they would go ahead and give another 12 milligrams if the rhythm remained unchanged. What they found was an 85% success rate in patients that were successfully converted to sinus rhythms. And complications did occur in these patients, though minor. They were seen in 9% of the patient population. Generally, it consisted of chest pain, flushing, headache, etc. There wasn't any serious complications, and the complications seen were generally transient. Following that study in 2000, this was a study that looked at adenosine 12 milligrams versus 18 milligrams. The study was relatively small and included a patient population of 31 patients. but they wanted to see if the 18 milligram dose would be superior to the 12 milligram dose for termination of SVT. They found that the 12 milligram dose ended up terminating SVT in 81% of the patients, followed by the 18 milligram dose terminating in 94% of the patient population. They did not note any serious complications, but what they did note was that the patients that were receiving the 18 milligram groups had more prolonged periods of asystole, and so the overall recommendation based on this small trial was to go ahead and try that 12 milligrams. And if patients aren't converting back to normal sinus rhythms, it seemed feasible to go ahead and try an 18 milligram dose for termination of SVT. And so now when we jump into the actual guideline recommendation, both the 2015 AHA guidelines and the 2020 Adult Basic and Advanced Life Support guidelines recommend vagal removers as first-line treatment therapy for patients that are presenting with stable SVT. Really the goal of these vagal removers is to increase vagal parasympathetic tone and thereby decrease the heart rate for these patients. There's a variety of different methods that you can try in regards to vagal removers. However, success rates do vary depending on the type of maneuver that was completed, and also just based on the studies that you looked at, and this variation ranges from 6% up to 54% of success rates, depending on where you look again. And then when it comes to the actual recommendations for medical management, if they fail vagal maneuvers, adenosine is recommended as a 1B recommendation for patients who are hemodynamically stable. And as we looked at the prior evidence on the previous slide, we saw that evidence comparing initial doses of adenosine for SVT termination is limited and generally includes sequential dosing, largely based on that study that was done in 1990. So this trial that we're talking about today was a multi-center retrospective cohort study that looked at 5 of the highest patient volume EDs in a single health system composed of teaching and community hospitals. They looked at data that was collected from administration records of adenosine and confirmed EKG readings of patients that had SVT. It was conducted from January 1st, 2020 to June 30th, 2022. When we look at the inclusion and exclusion criteria, this trial included patients who were receiving either a dose of 6 milligrams of adenosine or a dose of 12 milligrams of adenosine that were aged greater than 18 or greater years of age with hemodynamically stable SVT. For exclusions, they excluded pregnant patients, certain medications such as theophylline, carbamazepine, and dipyramidol. Also, if they were a recipient of electrical cardioversion prior to adenosine, adenosine was given via a central line, administered some sort of rate or rhythm control agent prior to the administration of adenosine, and diagnosis of hypervolemia or some sort of other underlying dysrhythmia. And so the main goal of this trial, given the lack of direct comparison of dosing in the literature available for 6 milligrams versus 12 milligrams, was to evaluate the rate of SVT termination between a 6 milligram group and a 12 milligram group as an initial adenosine dose in the emergency department. Other data points that they were looking at were secondary outcomes of termination of SVT with subsequent adenosine dosing. Termination with subsequent adenosine dosing was defined as an adenosine dose which terminated SVT within 30 minutes of unsuccessful initial dose, and also time to ED disposition. That was basically when the patient arrived to the time when they either were discharged or were admitted, had some sort of admission order. Safety outcomes included heart rate and blood pressure prior to and after adenosine administration, and any sort of sustained heart block of any degree. They also had subgroup analysis that included patients with a BMI of 40 or more and a history of SVT. When it comes to the statistical analysis of this study, so they estimated based on sample size calculations the assumption that the population would be split into 60% for the 6 milligram dose and 40% for the 12 milligram dose. They used student t-tests for continuous variables and chi-square and Fisher's exact for categorical variables. And when it comes to the actual patient flow chart, they screened for eligibility. They screened 354 patients. They excluded 141 patients. Most common reason for exclusion ended up being a rhythm other than SVT in 95 patients, followed by patients who were either given a calcium channel blocker or beta blocker prior to the trial of adenosine. Other category, which is for various reasons, such as patients being pregnant, administered via central line, etc. For inclusion, they included 213 patients. 117 were placed in the 6 milligram initial dose, and 96 were in the 12 milligram initial dose. When it comes to baseline characteristics, study included primary female 61.5%, Mean age was 55, BMI, or average BMI was 30.7. They had 34.2% of patients that had a history of SVT in the 6 milligram group and 44.8% of patients with a history of SVT in the 12 milligram group. When it comes to the utilization of vagal removers, only 30.5% of the patients had vagal removers tried before the administration of adenosine. Prior caffeine consumption was something they also looked at, and they only saw 1.4% of the study population having some sort of caffeine ingestion prior to the administration of adenosine. As for results, primary and secondary objectives, so again, there was 213 patients. Of those 213 patients, 142 patients terminated SVT with an initial dose. That was 66.7% of the population. 66 patients terminated in the 6 milligram groups, and 76 patients terminated in the 12 milligram group. When we look at patients that received a subsequent dose, there were 53 patients who did end up requiring another dose. The majority were in the 6 milligram group. 46 patients did receive another dose, and then 7 patients did not end up, 7 patients did receive a dose in the 12 milligram group as well. Looking at the patients that ended up receiving that subsequent dose, we see that 33 out of the 46 patients, so a little bit over 70%, ended up terminating when given another 6 milligram dose in the 6 milligram group. And then 1 out of the 7 patients ended up terminating their SVT rhythm when given a subsequent dose of adenosine. When we look at time to ED disposition, we can see on average all the patients had a time of 191 minutes. When we look at 6 milligrams versus 12 milligrams, we see that 209 minutes to ED disposition in the 6 milligram group versus the 12 milligram group, we see 161 minutes. This was not statistically significant, but there was a trend towards faster resolution in the 12 milligram group. Discharge from ED and also admission to inpatient seemed to be about equivalent across both groups. There was not many differences between the 6 milligram and the 12 milligram group. When we look at safety outcomes, so heart rate prior to adenosine administration was approximately 178 across all groups. Heart rate after adenosine was 99 in the 6 milligram group and 109 in the 12 milligram group. Sustained heart block was seen in 14 patients, which was evenly divided as 7 patients and 7 patients in the 6 milligram group and the 12 milligram group. Blood pressure prior to adenosine administration was a 123 over 84, seemed to remain about stable or about equivalent after adenosine administration as well. And it goes to the results of the different subgroups that this study looked at. So there were 32 patients that were included in this subgroup of BMI greater than or equal to 40. There were 17 patients out of the 32 patients that terminated with SVT of an initial dose. And when you break it down by the different 6 milligram and 12 milligrams groups, you can see that 8 patients ended up terminating in the 6 milligram groups, which came to a percent of 42.1% of the patients, and 9 patients, or 69.2% of the patients in the 12 milligram group. This was not statistically significant of note as well, just a trend towards higher conversion rates in the 12 milligram group. For history of SVT, there were 83 patients that had a history, 40 patients in the 6 milligram group, and 43 patients in the 12 milligram. For termination of SVT with the initial dose, 67.5% terminated in the 6 milligram group versus 79.1% that terminated in the 12 milligram group. Again, not statistically significant, just a trend towards higher conversion in the 12 milligram group. For the author's conclusion, so authors concluded that an initial adenosine dose of 12 milligrams achieved a significantly higher rate of SVT termination in comparison to an initial dose of 6 adenosine. When looking at the strengths and limitations of this trial, so again, guidelines were largely derived from studies that were performed in the 1990s. So this was the first attempt to compare rates of SVT termination in doses of 6 milligrams versus 12 milligrams in the actual ED. When we look at limitations of this trial, so this was a retrospective design. With that does come some limitations, such as you are limited to the documentation that is available to you or to the reviewer of this information. So one of the things of note is the side effects. Not every side effect may have been documented in the actual documentation. There potentially could have been more side effects than were actually noted or recognized in the study. Also, administration techniques is a big thing. This is something that's widely looked at and widely discussed. given that adenosine, one of the complications of giving this medication is the thought process of how are you going to give it, given that there are so many varieties of ways that you can give it. So that was something that wasn't discussed in this trial. We don't know how people were given the adenosine. We just know that they were given it. In addition, the subgroups that they looked at, there was a low number of patients with BMI greater than 40, which, again, in literature, there are studies looking at adenosine dosing in patients with higher BMIs, looking at the potential need to increase dosing of patients that are overweight. This study did not have enough patients and also did not need statistical significance to look at this specifically. And when it comes to the clinical application of this, we do see higher rates of conversion seen in the 12 milligram group. And just as a refresher, it was 56.4% in the 6 milligram versus 79.1% in the 12 milligram group. When we looked at subsequent adenosine dosings after the 6 milligram, there were 46 patients that needed an additional dose or that received an additional dose. That resulted in termination of 33 out of the 46 patients. This is relatively similar to the study performed in 1994 by Gesh et al. That was that pre-hospital study of the 12 milligrams into patients, again, pre-hospital. They did not have any sort of comparator dose. This trial does, which is nice to see the comparison of a 6 milligram dose versus the 12 milligram dose. Another thing was the faster disposition times that were observed in this trial. That potentially could be due to less time required for stabilization in these patients. Not really clear why. Again, it wasn't statistically significant, just a trend towards faster disposition times in the higher dose. As for safety analysis, this did not demonstrate any significant differences between the two groups. And then questions that still remain regarding this, again, is best administration techniques. There are several small studies looking at administration techniques. For instance, there was one that was completed in 2020 looking at a single syringe versus a stop clock. When you look at these trials, the majority of them either meet non-inferiority or are small. In that trial that I mentioned, the 2020, you may see higher terminations in that single syringe method, but again, it was a small study that did not really assess. It was a non-inferiority trial. And then again, administration through a central line. This data comes largely from a 1993 study that was looking at dosing in a central line versus a peripheral line. And they saw that lower dosing is effective for these patients at 3 milligrams. And then also just the utilization of an initial 12 milligram dose, given the limitations of this trial, and also really one of the first trials to be looking at a 6 milligram versus 12 milligram dose. We don't really have enough evidence to be giving this in all patients up front. And so with that, these are my references, and I am now open to any questions you guys may have.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.